An abdominal aortic aneurysm, AAA, is a bulge in the aorta, the large blood vessel that carries blood from the heart to the rest of the body, located in the abdomen. It occurs when the walls of the aorta weaken and stretch, increasing the risk of rupture, which can be life-threatening. Important points to remember for exams include risk factors such as smoking, high blood pressure, and a family history of vascular disease. Symptoms may include a pulsating feeling near the navel, sudden severe pain in the abdomen or back, and potential shock if it ruptures. Diagnosis is typically made through imaging tests like ultrasound or CT scans, and treatment may involve monitoring small aneurysms or surgical intervention for larger or symptomatic ones. Aortic stenosis is a condition where the aortic valve, which controls blood flow from the heart to the aorta, becomes narrowed or stiff. This narrowing makes it harder for the heart to pump blood out to the body, leading to symptoms like chest pain, shortness of breath, and fatigue, especially during physical activity. Important points to remember for exams include common causes such as age-related calcification, congenital heart defects, and rheumatic fever. Diagnosis is often made through a physical exam, where a doctor may hear a characteristic heart murmur, and confirmed with echocardiography. Treatment options include monitoring for mild cases, but severe cases may require surgical intervention, such as valve replacement. Atherosclerosis is a condition characterized by the buildup of plaque, made up of fat, cholesterol, and other substances inside the arteries, which can lead to narrowed or blocked blood flow. When this process affects the coronary arteries, it can result in acute coronary syndrome, ACS, which includes conditions like unstable angina and myocardial infarction, heart attack. Important exam points include understanding risk factors such as high cholesterol, smoking, high blood pressure, diabetes, and a sedentary lifestyle. Symptoms of ACS may include chest pain, shortness of breath, and discomfort in the arms, back, neck, or jaw. Diagnosis often involves an electrocardiogram, ECG, and blood tests, while treatment may include medications, lifestyle changes, and possibly procedures like angioplasty or bypass surgery to restore blood flow. Atrial fibrillation, AF, is a common heart rhythm disorder where the upper chambers of the heart, called the atria, beat irregularly and rapidly, leading to an ineffective pumping action. This can result in symptoms like palpitations, fatigue, shortness of breath, and an increased risk of blood clots, which can cause strokes. Important points for exams include recognizing risk factors such as hypertension, heart disease, diabetes, and age. Diagnosis is typically made through an electrocardiogram, ECG, which shows the irregular heartbeat. Treatment options may include medications to control heart rate or rhythm, anticoagulants to prevent blood clots, and procedures like cardioversion or ablation to restore a normal heart rhythm. Understanding the management of AF is crucial, as it significantly impacts patient outcomes. Atrial myxoma is a type of tumor that typically forms in the left atrium of the heart and is the most common primary heart tumor in adults. These tumors are usually benign, non-cancerous, but can cause significant problems by obstructing blood flow or leading to embolism if parts of the tumor break off and travel to other parts of the body. Important exam points include recognizing symptoms such as shortness of breath, chest pain, fatigue, and sometimes signs of systemic embolization like stroke. Diagnosis is often made using echocardiography, which can visualize the tumor and assess its impact on heart function. Treatment usually involves surgical removal of the myxoma, which can lead to a good prognosis if done promptly. Understanding the clinical presentation and management of atrial myxoma is essential for effective patient care. Atrioventricular AV block is a condition where the electrical signals between the heart's atria, upper chambers, and ventricles, lower chambers, are partially or completely blocked, disrupting normal heart rhythm. This can lead to slow heart rates and symptoms such as dizziness, fatigue, fainting, or even heart failure in severe cases. AV blocks are classified into 3 degrees. First-degree AV block involves a delay in signal conduction, but all impulses reach the ventricles. Second-degree AV block is where some signals are blocked, leading to dropped beats, Mobitz type 1 and 2. Third-degree complete AV block is where no signals reach the ventricles, causing them to beat independently. Diagnosis is typically made using an electrocardiogram, ECG, which shows the characteristic patterns of signal disruption. Treatment depends on the severity and may range from monitoring to the use of pacemakers in more severe cases, particularly in second-degree Mobitz 2 and third-degree blocks. Understanding the types, diagnosis, and management of AV block is crucial for preventing complications and ensuring patient safety. Cardiac anatomy refers to the structure of the heart, a muscular organ responsible for pumping blood throughout the body. The heart is divided into 4 chambers, 2 upper atria and 2 lower ventricles, separated by valves that ensure one-way blood flow. These include the mitral and tricuspid valves between atria and ventricles, and the aortic and pulmonary valves at the exits of the ventricles. Key blood vessels associated with the heart include the aorta, pulmonary arteries and veins, and the coronary arteries that supply the heart muscle itself. Understanding cardiac anatomy is essential for recognizing how diseases affect heart function. Cardiac biomarkers are substances released into the blood when the heart is damaged or stressed. They are crucial for diagnosing and managing heart conditions. Important biomarkers include troponins, which are highly specific for myocardial infarction, and B-type natriuretic peptide, BNP, which is used to assess heart failure. These biomarkers help clinicians evaluate the extent of heart damage and guide treatment decisions, making them vital knowledge for exams in cardiology. Coarctation of the aorta is a congenital heart defect, characterized by a narrowing of the aorta, the large artery that carries oxygen-rich blood from the heart to the rest of the body. This narrowing typically occurs just after the arteries that supply blood to the upper body, leading to high blood pressure before the point of coarctation and lower blood pressure beyond it. Important exam points include recognizing symptoms such as high blood pressure, especially in the arms, headaches, leg cramps during exercise, and in severe cases, heart failure or shock in infants. Diagnosis is often made through physical examination, where differences in blood pressure between the arms and legs are noted, and confirmed with imaging studies like echocardiography, MRI, or CT scans. Treatment may involve surgical repair or balloon angioplasty to widen the narrowed section. Understanding the clinical presentation, diagnostic approach, and treatment options for coarctation of the aorta is critical for effective management and patient outcomes. Congenital rubella syndrome, CRS, occurs when a pregnant woman is infected with the rubella virus, particularly during the first trimester, leading to a range of serious birth defects in the developing fetus. Important exam points include the classic triad of symptoms associated with CRS, cardiac abnormalities, such as patent ductus arteriosus and pulmonary artery stenosis, eye defects, like cataracts and retinopathy, and hearing impairment. These conditions arise because the virus can interfere with the normal development of the heart, eyes, and ears. Other potential manifestations include growth retardation, and developmental delays. Diagnosis of CRS is typically made based on clinical features and confirmed by laboratory testing for rubella-specific IgM antibodies in the infant's blood. Preventing CRS is a major public health focus, achieved primarily through vaccination of women of childbearing age with the MMR, measles, mumps, rubella vaccine. Understanding the transmission, clinical features, and prevention strategies for congenital rubella is crucial in cardiology and pediatrics, given the significant impact on cardiovascular and systemic health. Deep venous thrombosis, DVT, is a condition where a blood clot forms in a deep vein, usually in the legs, which can lead to serious complications if not treated promptly. Key points for exams include recognizing symptoms such as swelling, pain, warmth, and redness in the affected leg, although it can sometimes occur without any symptoms. The clot can pose a risk of breaking free and traveling to the lungs, causing a life-threatening condition called pulmonary embolism, PE. Risk factors for DVT include prolonged immobility, such as during long flights or bed rest, surgery, certain medical conditions, and inherited clotting disorders. Diagnosis of DVT is often confirmed through ultrasound imaging of the affected area. Treatment typically involves anticoagulant medications to prevent clot growth and reduce the risk of PE. In some cases, compression stockings or filters inserted into the vena cava may be used to prevent complications. Understanding the risk factors, symptoms, diagnostic methods, and treatment strategies for DVT is essential, as timely intervention can prevent serious outcomes. Dilated cardiomyopathy, DCM, is a condition where the heart's chambers, particularly the left ventricle, become enlarged and weakened, leading to impaired pumping ability and heart failure. For exams, it's important to understand that this condition can result from various causes, including genetic factors, infections, alcohol abuse, and certain medications. Key symptoms to recognize include fatigue, shortness of breath, swelling in the legs and ankles, and irregular heartbeats. The heart's inability to pump effectively can lead to fluid buildup in the lungs and body, contributing to these symptoms. Diagnosis is typically made using echocardiography, which shows the enlarged heart chambers and reduced pumping function, alongside other tests like chest X-rays and MRIs. Treatment focuses on managing symptoms and improving heart function through medications such as ACE inhibitors, beta blockers, and diuretics, along with lifestyle changes. In severe cases, devices such as pacemakers or heart transplants might be necessary. Understanding the causes, symptoms, diagnostic methods, and treatment options for DCM is crucial for effectively managing this complex condition. Endocarditis is an infection of the inner lining of the heart chambers and valves, known as the endocardium. It's commonly caused by bacteria entering the bloodstream and attaching to damaged areas of the heart, often where there are pre-existing valve defects or artificial valves. Important exam points include recognizing symptoms such as fever, chills, fatigue, heart murmur, and signs of embolism like petechiae, small red spots on the skin, Osler's nodes, and Janeway lesions. Endocarditis can lead to severe complications like heart failure, stroke, or systemic emboli if untreated. Diagnosis is made through blood cultures to identify the causative organism and echocardiography to visualize vegetations, clumps of microbes and cells, on the valves. Treatment typically involves prolonged courses of intravenous antibiotics, and in some cases, surgery may be necessary to repair or replace damaged valves. Preventive measures, such as antibiotic prophylaxis before certain dental or surgical procedures, are important for those at high risk. Understanding the causes, clinical manifestations, diagnostic strategies, and management of endocarditis is crucial for effective patient care and exam success. Wegener's granulomatosis, now more commonly known as granulomatosis with polyangiitis, GPA, is a rare autoimmune disease characterized by inflammation of small and medium-sized blood vessels, leading to damage primarily in the respiratory tract and kidneys. For exam purposes, it's crucial to recognize its classic triad of symptoms: upper respiratory tract involvement, such as sinusitis and nasal crusting, lower respiratory tract issues, like cough and hemoptysis, and kidney problems, often presenting as rapidly progressing glomerulonephritis. Other symptoms can include joint pain, skin rashes, and eye inflammation. Diagnosis is supported by laboratory tests showing elevated levels of C-ANCA, anti-neutrophil cytoplasmic antibodies, and confirmed by biopsy of affected tissues, revealing necrotizing granulomatous inflammation. Treatment typically involves immunosuppressive medications, such as corticosteroids and cyclophosphamide, to control the inflammation and prevent organ damage. Understanding the clinical presentation, diagnosis, and management of GPA is vital, as early detection and treatment can significantly improve outcomes for patients. Heart failure is a chronic condition where the heart is unable to pump blood effectively to meet the body's needs, often leading to a buildup of fluid in the lungs and other parts of the body. Important points for exams include recognizing the key symptoms such as shortness of breath, fatigue, swollen legs and ankles, and difficulty breathing when lying down. Heart failure can result from various causes, including coronary artery disease, high blood pressure, and previous heart attacks, which weaken the heart muscle over time. Diagnosing heart failure involves clinical evaluation. Imaging tests like echocardiograms and laboratory tests such as measuring B-type natriuretic peptide, BNP levels, which increase with heart failure. Treatment focuses on relieving symptoms and improving heart function, typically using medications like ACE inhibitors, beta blockers, and diuretics to reduce fluid overload. Lifestyle changes, such as dietary modifications and exercise, are also crucial. In advanced cases, devices like pacemakers or ventricular assist devices, and even heart transplants, might be needed. Understanding the causes, symptoms, diagnostic approaches, and management strategies for heart failure is essential for providing comprehensive care and improving patient outcomes. Hypertension, commonly known as high blood pressure, is a condition where the force of blood against the artery walls is consistently too high, which can lead to serious health problems like heart disease and stroke. For exam purposes, it's important to know that hypertension is often called the silent killer because it may not show symptoms until significant damage has occurred. Blood pressure is measured in millimeters of mercury, mmHg, and comprises two numbers: systolic, pressure when the heart beats, over diastolic, pressure when the heart rests between beats. A normal reading is typically around 120/80 mmHg, while hypertension is diagnosed at 140/90 mmHg or higher. Risk factors include obesity, a high-salt diet, lack of physical activity, smoking, excessive alcohol consumption, and genetics. Diagnosis is straightforward, involving regular blood pressure measurements. Management includes lifestyle modifications, such as a balanced diet, regular exercise, and weight loss, along with medications like diuretics, ACE inhibitors, and calcium channel blockers to control the condition. Understanding how to diagnose, treat, and manage hypertension is crucial because effective control can prevent complications and improve quality of life. Hypertrophic cardiomyopathy, HCM, is a genetic heart disorder where the heart muscle, particularly the left ventricle, becomes abnormally thickened, which can make it harder for the heart to pump blood efficiently. For exam purposes, it's crucial to understand that this thickening can lead to problems such as obstructed blood flow out of the heart, irregular heart rhythms, arrhythmias, and potentially sudden cardiac death, especially in young athletes. Symptoms might include chest pain, shortness of breath, dizziness, and fainting, often during or after exercise. HCM is typically diagnosed through echocardiography, which reveals the thickened heart muscle, and sometimes genetic testing to identify mutations in specific genes. Treatment focuses on managing symptoms and preventing complications using medications like beta blockers or calcium channel blockers to reduce heart workload, and potentially surgical procedures or alcohol septal ablation to reduce muscle thickness. In some cases, an implantable cardioverter defibrillator, ICD, might be recommended to prevent sudden death. Understanding the genetic basis, clinical features, diagnostic strategies, and management of HCM is essential for providing appropriate care and counseling to patients and their families. Kawasaki disease is an acute, self-limiting vasculitis that primarily affects children under the age of 5 and is characterized by inflammation of the blood vessels throughout the body. For exams, it's important to recognize the classic symptoms, which include prolonged fever lasting more than 5 days, a rash, swelling of the hands and feet, red eyes, conjunctivitis, swollen lymph nodes in the neck, and red, cracked lips and strawberry-like tongue. A key concern with Kawasaki disease is its potential to cause coronary artery aneurysms, which can lead to serious heart complications if not treated promptly. Diagnosis is clinical, based on the presence of characteristic symptoms and exclusion of other conditions. Treatment typically involves high-dose aspirin and intravenous immunoglobulin, IVIG, to reduce inflammation and prevent coronary artery damage. Early intervention is crucial to minimize the risk of long-term cardiovascular complications. Understanding the clinical presentation, potential complications, and treatment strategies for Kawasaki disease is essential for effective pediatric care and for ensuring better outcomes for affected children. Mesenteric ischemia is a serious condition where there is a reduction of blood flow to the intestines, often due to a blockage in one or more of the major arteries supplying the digestive tract. This condition can be acute or chronic, with acute mesenteric ischemia representing a medical emergency. For exams, it's critical to recognize the hallmark symptom of sudden and severe abdominal pain out of proportion to physical examination findings in acute cases. Chronic mesenteric ischemia, on the other hand, often presents with postprandial abdominal pain, pain after eating, weight loss, and fear of eating due to discomfort. Causes include embolism, thrombosis, or atherosclerosis affecting the mesenteric arteries. Diagnosis typically involves imaging studies like CT angiography to visualize blood flow and pinpoint blockages. Treatment depends on the severity and underlying cause, but may include revascularization procedures such as angioplasty with stenting or surgical bypass to restore adequate blood flow. Early diagnosis and intervention are crucial to prevent bowel necrosis, which can lead to life-threatening complications. Understanding the causes, clinical manifestations, diagnostic techniques, and treatment options for mesenteric ischemia is vital for effective management and improved patient outcomes. Mitral valve prolapse, MVP, is a condition where the mitral valve, located between the left atrium and left ventricle of the heart, doesn't close properly. In MVP, one or both of the valve's leaflets bulge or prolapse backward into the atrium during heart contraction. For exams, it's important to note that while MVP is often benign and asymptomatic, it can sometimes cause symptoms like palpitations, chest pain, fatigue, or shortness of breath. MVP is usually discovered during a physical exam when a doctor hears a distinctive clicking sound or murmur through a stethoscope. Diagnosis is confirmed with echocardiography, which shows the prolapse of the mitral valve leaflets. Although serious complications are rare, MVP can sometimes lead to mitral valve regurgitation, where blood leaks backward into the atrium, or rarely, arrhythmias or endocarditis. Most individuals with MVP require no specific treatment beyond regular monitoring. However, in cases with significant mitral regurgitation, surgical repair or replacement of the valve may be necessary. Understanding the clinical features, diagnostic approach, and management of mitral valve prolapse is crucial for providing appropriate care and reassurance to patients. A myocardial infarction, commonly known as a heart attack, occurs when blood flow to a part of the heart is blocked, typically by a blood clot, causing damage to the heart muscle. For exams, it's essential to recognize the classic symptoms, which include chest pain or discomfort that may radiate to the arm, neck, jaw, or back, along with shortness of breath, sweating, nausea, and sometimes lightheadedness. The blockage is usually due to a buildup of fatty deposits or plaques in the coronary arteries, a condition known as atherosclerosis. Diagnosing a myocardial infarction involves clinical evaluation, electrocardiograms, ECGs, to detect heart rhythm changes, and blood tests to measure cardiac enzymes like troponins, which rise when the heart muscle is injured. Immediate treatment aims to restore blood flow quickly, often using medications such as aspirin, clot busters, thrombolytics, or procedures like angioplasty with stenting. Long-term management includes lifestyle changes, medications to prevent further clots, and monitoring for complications such as arrhythmias or heart failure. Understanding the pathophysiology, symptoms, diagnostic criteria, and treatment strategies for myocardial infarction is crucial for saving lives and improving patient outcomes. Patent ductus arteriosus, PDA, is a congenital heart defect where the ductus arteriosus, a normal fetal blood vessel that connects the aorta and the pulmonary artery, fails to close after birth as it should. This condition results in abnormal blood flow between the aorta and pulmonary artery, allowing oxygen-rich blood from the aorta to mix with oxygen-poor blood in the pulmonary artery. For exams, it is crucial to understand that this can lead to increased blood flow to the lungs, which may cause respiratory issues and heart strain. PDA is more common in premature infants, and symptoms can vary depending on the size of the ductus. Small PDAs might be asymptomatic, whereas larger ones can cause signs such as rapid breathing, poor feeding, and failure to thrive. Diagnosis is often made with a heart murmur heard during a physical exam and confirmed with echocardiography. Treatment may involve monitoring for spontaneous closure in small PDAs, medical management with medications like indomethacin or ibuprofen in premature infants, or interventions such as catheter-based procedures or surgery to close the ductus in larger or symptomatic cases. Understanding the physiological impact, clinical presentation, diagnostic techniques, and treatment options for PDA is essential for managing affected infants and improving their outcomes. Pericarditis is the inflammation of the pericardium, the thin, double-layered sac that surrounds the heart, often leading to chest pain and other symptoms. For exams, it's important to recognize that the chest pain associated with pericarditis is typically sharp and worsens with deep breathing, lying flat, or coughing, and may improve when sitting up and leaning forward. This pain can sometimes mimic that of a myocardial infarction, but the positional nature of the pain is a key distinguishing feature. Pericarditis can have various causes, including viral infections, bacterial infections, autoimmune conditions, and myocardial infarction, among others. Diagnosis is often supported by the presence of a characteristic friction rub heard upon auscultation. Changes in the electrocardiogram, ECG, such as diffuse ST segment elevation, and imaging studies like an echocardiogram to assess for pericardial effusion. Treatment typically involves anti-inflammatory medications such as NSAIDs or colchicine to reduce inflammation and relieve symptoms, with corticosteroids used in more severe or refractory cases. Recognizing the clinical presentation, underlying causes, diagnostic processes, and appropriate management of pericarditis is crucial for effective patient care and preventing complications such as cardiac tamponade or chronic pericardial constriction. Polyarteritis nodosa, PAN, is a rare and serious vasculitis that involves the inflammation of small to medium-sized arteries, which can lead to damage in various organ systems due to reduced blood flow. For exams, it's essential to understand that PAN can affect multiple organs, most commonly the kidneys, gastrointestinal tract, nerves, skin, and sometimes the heart, but it usually spares the lungs. Patients may present with a diverse range of symptoms, including fever, weight loss, muscle and joint pain, abdominal pain, skin rashes or nodules, high blood pressure, and peripheral neuropathy. The exact cause of PAN is not well understood, but it may be associated with hepatitis B infection or other immune system issues. Diagnosis is challenging and typically involves a combination of clinical evaluation, blood tests showing elevated inflammatory markers, and tissue biopsy of affected organs. Angiography can also be used to identify characteristic aneurysms in medium-sized arteries. Treatment generally includes high-dose corticosteroids and immunosuppressive drugs to control inflammation and prevent organ damage. Recognizing the heterogeneous symptoms, diagnostic challenges, and treatment strategies for polyarteritis nodosa is crucial for timely intervention and improving patient outcomes. Rheumatic heart disease is a chronic heart condition caused by rheumatic fever, an inflammatory disease that can develop after an untreated or inadequately treated streptococcal throat infection. This condition primarily affects the heart valves, leading to permanent damage, and is most common in children and young adults, particularly in developing countries. For exams, it's important to recognize that rheumatic heart disease often results in valve stenosis, narrowing, or regurgitation leakage, with the mitral valve being most frequently affected. Symptoms can include shortness of breath, chest pain, fatigue, and swelling in the legs, which may develop years after the initial rheumatic fever episode. Diagnosis is based on the clinical history of rheumatic fever, echocardiography to assess valve damage, and possibly blood tests for markers of inflammation or evidence of prior streptococcal infection. Treatment focuses on preventing recurrent rheumatic fever with long-term antibiotics, managing heart failure symptoms, and in some cases, surgical repair or replacement of the damaged valves. Understanding the pathophysiology, clinical manifestations, diagnostic criteria, and management strategies for rheumatic heart disease is crucial for preventing complications and improving the quality of life for affected individuals. Temporal arteritis, also known as giant cell arteritis, is an inflammatory condition affecting the large and medium-sized arteries, particularly the temporal arteries located on the sides of the head. This condition is most common in older adults, typically over the age of 50, and more frequently affects women. For exams, it's critical to recognize the classic symptoms, which include new onset, severe headaches, scalp tenderness, jaw pain when chewing, jaw claudication, and sometimes visual disturbances, which can lead to serious complications such as blindness if not promptly treated. Diagnosis is often supported by elevated inflammatory markers like the erythrocyte sedimentation rate, ESR, and C-reactive protein, CRP, in blood tests and confirmed by a temporal artery biopsy showing characteristic inflammatory changes. Immediate treatment with high-dose corticosteroids is crucial to prevent vision loss and manage symptoms. Understanding the clinical presentation, diagnostic approach, and urgent treatment requirements for temporal arteritis is essential for effective patient care and preventing irreversible complications. Tetralogy of Fallot is a congenital heart defect that consists of 4 anatomical abnormalities in the heart that affect blood flow. These include a ventricular septal defect, a hole between the heart's lower chambers, pulmonary stenosis, narrowing of the outflow tract from the right ventricle to the pulmonary artery, right ventricular hypertrophy, thickening of the right ventricular muscle, and an overriding aorta, where the aorta is positioned above the ventricular septal defect and receives blood from both ventricles. For exams, it's important to understand that these defects cause oxygen-poor blood to flow out of the heart and into the body, leading to cyanosis, which manifests as a bluish tint to the skin, lips, and nails due to low oxygen levels. Symptoms commonly appear in infancy or early childhood and can include episodes of cyanosis, often called tet spells, difficulty breathing, and fatigue during feeding or exercise. Diagnosis is typically confirmed with echocardiography and sometimes cardiac catheterization. The mainstay of treatment is surgical repair, usually performed early in life, to correct the defects and improve blood flow and oxygen levels. Understanding the anatomical abnormalities, clinical presentation, diagnostic techniques, and treatment strategies for tetralogy of Fallot is crucial for improving outcomes and quality of life for affected children. Truncus arteriosus is a rare congenital heart defect where a single blood vessel, instead of 2 separate vessels, emerges from the heart's ventricles, supplying blood to both the systemic and pulmonary circulations. In a normal heart, the pulmonary artery and the aorta are distinct, but in truncus arteriosus, they are combined, resulting in mixed oxygenated and deoxygenated blood being circulated throughout the body. For exams, it's crucial to note that this condition leads to symptoms such as cyanosis, a bluish tint to the skin due to low oxygen levels, difficulty breathing, poor feeding, and failure to thrive in newborns. Diagnosis is typically made via echocardiography, which reveals the single trunk and associated ventricular septal defect, VSD. Without surgical intervention, truncus arteriosus can lead to heart failure and severe complications early in life. Treatment involves surgical repair, usually within the first few weeks of life, to separate the single vessel into the aorta and pulmonary artery, and close the VSD, ensuring proper blood flow. Understanding the anatomical defect, clinical presentation, diagnostic process, and surgical treatment options for truncus arteriosus is vital for managing this complex condition and improving patient outcomes. Unstable angina is a type of acute coronary syndrome that occurs when there is a sudden reduction in blood flow to the heart muscle, often due to the rupture of a plaque in a coronary artery, but not necessarily resulting in a heart attack. It is characterized by chest pain or discomfort that is unexpected, occurs at rest, or with minimal exertion, and varies in intensity, frequency, or duration compared to stable angina. This type of angina is a medical emergency because it indicates that the heart is not receiving enough oxygen and nutrients, which could lead to a heart attack if not promptly treated. For exams, it's important to recognize that patients may present with chest pain that radiates to the arms, neck, jaw, or back, and may be accompanied by other symptoms such as shortness of breath, nausea, or sweating. Diagnosis typically involves clinical evaluation, electrocardiogram, ECG, to rule out myocardial infarction, and blood tests to check for cardiac biomarkers like troponins, which are usually normal in unstable angina but elevated in a heart attack. Management includes medications such as antiplatelets, e.g. aspirin, anticoagulants, beta blockers, nitrates, and statins, along with lifestyle modifications and sometimes revascularization procedures like angioplasty. Understanding the clinical presentation, diagnostic strategy, and management of unstable angina is crucial for preventing progression to a heart attack and ensuring patient safety. Wolff-Parkinson-White (WPW) syndrome is a type of pre-excitation syndrome where an additional electrical pathway, known as an accessory pathway, exists between the atria and ventricles of the heart. This accessory pathway allows electrical signals to bypass the heart's normal conduction system, leading to episodes of tachycardia or abnormally fast heart rhythms. For exams, it is crucial to understand that WPW can be identified on an electrocardiogram, ECG, by the presence of a short PR interval and a characteristic delta wave, which is a slurred upstroke in the QRS complex. Patients with WPW syndrome may experience palpitations, dizziness, shortness of breath, or syncope, fainting, and in some cases it can lead to more serious arrhythmias that require immediate intervention. Diagnosis is confirmed through ECG and sometimes electrophysiological studies. Treatment options may include medications to control the heart rate during episodes, but definitive treatment often involves catheter ablation, a procedure that destroys the accessory pathway and restores normal heart rhythm. Understanding the pathophysiology, clinical presentation, diagnostic features, and treatment options for WPW syndrome is essential for managing this condition and preventing potentially serious complications.